we're going to switch gears, head back up to the ankle, and start talking about syndesmotic injuries. Samir Mehta will be the moderator for that session, and I want to thank Acumed for being our corporate sponsor for the next session. Thanks, Samir.
Well, good morning, everyone. It is truly an honor to be part of this. Selene, thank you for inviting us. We've got an esteemed panel for our syndesmotic discussion. And so I have Mac Hogan, who's the chair at the University of Pittsburgh. Mac is hopefully going to join us very shortly, but we're going to get started. Michael Swords, who's medical director of orthopedic trauma at Sparrow Hospital. He does both foot and ankle and trauma, so he's going to balance us out. And then there's myself, who's an orthopedic traumatologist at the University of Pennsylvania. And so I always sometimes laugh about the term experts, and this is one of my favorite slides. What are experts? We've got a talent for explaining tomorrow why the predictions we made yesterday don't come true. And in some ways, I always tell people I live in a really, really big glass house that's already got lots of cracks in the windows and it's missing some windows. So, we talk about these issues or these items, but most of the things that we will talk about is because we've learned from our mistakes. So we're going to talk about the syndesmosis. We're going to do this case-based. There's lots of things to talk about with the syndesmosis. The reality is that there is issues with diagnosis. How do you do your intraoperative assessment? How do you reduce the syndesmosis, maintain that reduction, stabilize the syndesmosis? Are you using any adjunctive fixation strategies, and are there salvage techniques? And we'll also talk about post-operative protocols. And so after we're done in the next 5 hours talking about this, you'll realize that we haven't come to any solutions or any answers. And so sometimes when I think about the syndesmosis, I really feel like I'm not sure what to do with my hands. And I suspect the panel probably feels the same way with certain foot and ankle injuries, especially ones that involve the soft tissue of the syndesmosis. So with that, we're going to get started. Again, good morning to my panel. Good morning to the audience, or good evening or good afternoon, depending on where you are in the world. All right, first case. And these cases are going to range from pretty basic in terms of complexity to some controversial cases, hopefully. So this is a 28-year-old university football player who was tackled at practice, American football, not the rest of the world's kind of football, and had an immediate splint application and was diagnosed with a high ankle, a sprain, and a fibula fracture. So these are his x-rays or fluoro shot. I'll show you the fluoro shots. I don't have his x-rays, but Mac, when you see this, what are you thinking?
Sure. So obviously I'm thinking in this case, unstable injury. A lot of, I actually look at these in many cases based on the mechanism and how this occurred. If they had impact with another player, this is a higher energy trauma. And as the athletes get bigger, the amount of energy of the trauma gets bigger. So I'm thinking about the soft tissue envelope, what my treatment plan is going to be. But initially, how do we reduce this, get it in a better position for the soft tissues are my first thoughts.
Okay. So he's splinted and he's reduced, and the soft tissue acquiesce over. Let me take a step back. Either of you guys fixing this immediately? And what do you mean by immediate? Mac, would you fix these acutely?
So with this amount of soft tissue, with this amount of swelling and medial clear space widening, I more often will take a delay. But there are some scenarios if the soft tissue envelope is perfect. I mean, we see it that night where I have fixed these the next morning. But this is one that I would likely wait for the soft tissues to acquiesce over a series of days.
And so soft tissue swelling gets better. I think he sees me, in the clinic, 5-6 days later, and he's, soft tissue is ready for surgery. And so when you think about these syndesmotic injuries, this is always going to be controversial. And maybe I'll wait for Michael I'll ask Michael when he gets back on. Athletes now, let's take a step back. I mean, this is where, are you using rigid fixation or flexible fixation?
So I go in with both options. I use rigid. I use rigid and flexible, but I likely use flexible now more often. That has evolved in my practice since I began a decade ago. But I have both available. But it also depends on what all I'm going to repair and what type of stress I'm putting on that flexible fixation.
Okay, so if in an athlete, are you purposefully using flexible fixation more often, or are you saying, you know what, I'm still going to make a game time decision?
Yeah, I'm still going to make a game time decision, but I would say it's like 80 to it's about 90% to 10. But I know we're going to talk about some other soft tissue things here that really goes in and out with deltoid fixation, et cetera, as well. But
all right, they bring up some great things. All right, so we'll talk about the fibula very briefly because I want to focus mostly on the syndesmosis. So in terms of your syndesmotic assessment in the operating room, what kinds of things are you doing either preoperatively or intraoperatively to prepare yourself to figure out if you've correctly reduced the syndesmosis, recognizing that we do a horrible job fixing the syndesmosis in general if you look at some of the historical literature?
No, absolutely. In some of these, when they have a fracture such as this, I rarely get advanced imaging. If there's additional comminution, if there's a medial mal, I'm concerned there also may be a posterior malleolar component, and I really want to understand that configuration. I will prefer to have a CT scan. But in this case, with Weber C fracture configuration, I actually will intraoperatively really just look at the syndesmosis. So my exposure will take me down over the syndesmosis. I do like the concept of looking for the Mercedes sign there at that junction of the fibula, talus, and tibia, and doing my best to really position it in what I believe is the reduced position, recognizing everything that you mentioned, that we are not perfect at this in any way.
So I've heard that people are using intraoperative CT scan or using something like, again, I don't want to be company specific, but like an O-arm. Are you doing intraoperative CT to assess your syndesmosis?
I have not. I have not done that, intraoperative CT or O-arm. I do operate at some of our trauma centers where that technology is used, heavily by our either trauma surgeons such as yourself or our spine surgeons. But I've not pushed for that at this stage.
Okay. And the other question I have for you is, how often are you opening your syndesmosis to get your reduction? To look at your reduction.
I open nearly 100%. I mean, unless it is purely just ligamentous and I have a purely ligamentous injury, as confirmed by MRI with no fracture components. And even then, I really like to look at that anterior juncture there.
Okay. And so, how about contralateral films? Do you find a lot of value with contralateral films? Like in this case, you'll see I took images of the right side. And if you do, is there one view or another that you use if you're going to use contralateral films?
No, I think that, I mean, that's one I think I have not done that as much, but I can't say that is one that has, I think, gained more traction. I've definitely started doing it more and more with some of these larger linemen or individuals where it's really hard to stress some of these individuals. I mean, some of their calves are, their calves are bigger than my thighs in theory. So I can't get my hands around it to really stress them. So I actually like looking at the other side and also understanding their morphology.
Okay. So this is this gentleman's right ankle. I get an AP and a lateral, or I guess you should say a mortise view and a lateral. Look at where that fibula is sitting relative to the tibia. To me, the lateral view is a little bit more important. I don't open every syndesmosis. Maybe I should. I've gone back and forth about that during my career. I lag fixate the fibula, get it out to length, mini frag screws there. And then we get to There's your
Mm-hmm.
there's your fibula
Mm-hmm.
fixed out to length, and you've got that syndesmotic disruption. You've also got the medial clear space widening. So obviously this person has a syndesmotic injury. How do you intraoperatively assess syndesmotic stability, Mac?
So a combination of I will take a clamp and really just gap them. I will do an external rotation test, save all those images. I really like documenting that to really confirm how unstable the injury was. I think that's very important across the board, not just in athletes, just to make the point of why we're there and the long-term sequelae of the injury. And then I also will do a anterior posterior kind of shuck test, really more of an anterior posterior drawer of the fibula, if you will. I found that it's similar to what it seems like you've done here, at least with the medial lateral and Taylor shift stress test.
Yeah. So I think that is, I think there's different ways to do it. I tend to do everything I can to determine syndesmotic stability. Obviously, if there's syndesmotic instability with one test, I will buy it. But I'm trying to convince myself before I leave the operating room, is that syndesmosis unstable? And I will do everything I can to make sure that it is stable. So I go through every test. I know some people place a AO elevator into the syndesmosis and use that to stress the syndesmosis and gently apply pressure. So, Michael, how do you assess your syndesmosis after you fix the fibula?
I think there's a variety of different ways you can do it. People will talk about external rotation tests. If you literally just peek over the fibula anteriorly and you rotate the ankle, you can often see damage to the fibers. You can put some sort of instrument between the tibia and fibula and rotate it. Sometimes there's tearing the fibers, or you can put a small lamina spreader and see if you can distract it. I think there's a lot of different ways to do it. I think what you're really trying to do is convince yourself that it's stable. And sometimes these cases are not real clear, and you'll end up doing all of these to try to really make sure that at the end you're convinced it's stable.
I think that point is really critical. I think for the audience, you do not want to leave the operating room with an unstable syndesmosis. I think that is hypercritical, and it's one of the things I stress to my learners is, even if I'm nailing a distal third tibia, check that syndesmosis before you leave. I mean, seeing this happen late, I've seen that a couple of times. I'm sure you guys have as well in your career. It's a hard problem to solve, a 3-month or 6-month out syndesmotic disruption in a patient. Okay, so this gentleman you see here, we fixed his fibula, 20-year-old football player. Michael, flexible fixation or rigid fixation for this?
So, if you're to look at the key determinant what you use, I think the bigger issue is getting the reduction correctly. Certainly there's literature supporting a trend towards more flexible fixation, but many of us have used screws for a long time and have done well with those. I myself have transitioned more to flexible fixation, but I still think the most critical element is the reduction.
Do you buy the argument that with flexible fixation you can quote unquote drive your reduction better than you can if you put screws in? And the concept here, of course, is that the incisura of the tibia and the fibula if you just kind of put a little pressure on it with the one of these flexible fixation devices, that the fibula will find its way into the incisura and nestle itself, rather than a rigid screw that's going to drive your reduction and potentially malreduce your fibula. Do you buy that argument or no?
I don't buy it, because if you think about the fibula, it's not a one-dimensional reduction. It's not a medial to lateral reduction. It's also in the sagittal plane. It can be rotational. So if you were to miraculously drill in the exact correct plane, accounting for rotation, sagittal position, and coronal position, then your device might help you with a reduction. But we don't do that. There's no way you're going to get that. So you need to have your syndesmosis reduced before you insert your fixation element. Otherwise, if you're not reduced, you're more than likely going to introduce some form, or not just introduce some form of malreduction, but permanently hold something malreduced. And on my foot and ankle side of things, I do a lot of late syndesmotic reconstruction, and it used to be all screws and malreduction, and now the trend is malreduction with flexible fixation devices. So I don't think it really matters. It's the reduction. You need to be reduced whatever you're going to use for fixation.
Mac, do you think this kid's deltoid is still intact, or is it blown apart?
It's evolved. I mean, it's evolved. It's blown apart. It's sitting somewhere there.
And so what do you, and obviously a lot of these syndesmotic injuries come with other things. Tell me what your thoughts are. And I don't want to get, I know there's a whole session on deltoid, so I don't want to get into that because that's a separate box of trouble we're going to open. But are you fixing the deltoid regularly in a patient with a syndesmotic disruption, or are you waiting to fix the syndesmosis first and then stressing the deltoid?
So that's a great question. I fix more than I leave. There's a selection bias there that's personal. I had this exact fracture when I was 17, and they did not fix my deltoid back in 1998, and that's okay. I mean, but at the same time, so I do fix more of these, and I prefer to get the fibula out to length, but sometimes I start with the stress views initially that you showed at the beginning before any fixation, and if I find there's actually a soft endpoint, meaning when I'm really just doing that internal external rotation view, and I cannot close down the medial clear space to my liking or preference and feel, I will open early in that medial gutter. I will open early. I will place whatever fixation I'm using for that, and I will actually close as much of that medial wound as possible in a very low tension manner, and then fix the fibula and then finish everything at the end. I mean, so not always simple and straightforward, but that's my approach.
Just to clarify, when you say open the medial gutter and put some provisional fixation or low tension fixation, where is that incision and what do you use?
No, I pretty much go directly medial or anterior, directly medial or just a little anterior medially. I want to be able to see into the gutter if at all possible. Often their soft tissues will allow that if the swelling has gone down, and I'm not really concerned about wound closure, but being very careful with that, with all populations. And I prefer to use either one or two suture anchors from any company, or sometimes I'll use a double loaded. And I'll try to place one more medial, depending on the anatomy or morphology of their medial malleolus, and then one more medial and one deep and one superficial. Let's put it that way. And then I try to do a layer closure and imbrication, very similar to the approach I take when doing a lateral ligament stabilization. And I've had good early success with that, knock on wood. But that's my usual approach.
So next question I have is, if you are putting fixation across the syndesmosis, how much fixation are you using? I use this case as an example here. I use two 3.5 millimeter screws. Talk me through how you decide how much fixation, and then the next question will be, so you can already think about where I'm headed with this, is does your fixation and how much fixation you put in then dictate when you allow these patients to weight bear? So maybe Michael first, then Mac.
So, I typically am putting one fixation element. It used to be screws, and now I tend to use a bit more of a flexible device. It's kind of a combination of a screw flexible fixation device. Most of the time, my weight bearing advancement is dictated by other injuries, right? Did they have a posterior malleolar component? Was there an associated dislocation? Those are the things to me that really drive my weight bearing scenario. Was my fibula injury length stable? And if it was, that's something that I'd be more than likely to weight bear early. If it was not length stable, did I indirectly get the length back and use my syndesmotic device to hold it? And if that's the case, I'm not going to weight bear. If I used a plate, I will, because I have turned that into a length stable device. So I think there's a lot that goes into which ones you weight bear beyond what your fixation device is.
Mac, how about you?
Similar. I mean, my weight bearing is really based on all the injuries. I do believe this concept that suspensory or flexible fixation allows you to weight bear sooner is really a farce. I mean, it should not be used with the mindset that you're going to be able to mobilize or even rehab these individuals faster. I think it is patient specific and also based on those other injuries. And with that, I will use often two flexible fixation devices. Sometimes I would do hybrid with a screw. That's usually with a larger individual, and that is almost always in
And then,
combination.
before
Yeah.
Are you taking that, so that you bring up hybrid fixation,
Mhm,
and I was going to bring that up later,
mhm,
so I love that you brought that up now.
mhm.
Screw and syndesmosis and flexible fixation, so rigid and flexible. Some might call that schizophrenic. I'm not going to, because I do the same thing sometimes. Are you taking that screw out? That
in athletes, I prefer to remove it, and I tell them, I say, look, when they come to me, I say, you may have one procedure. Based on what I believe we need to do, there is always a possibility that you will have a second procedure, and that is often, and that occurs left often, this decade into my career. But I do advise them that if I get in there and I feel I need a screw to help stabilize things, particularly with a completely, grade 3 deltoid Weber C fracture subluxation, I mean, I want them to know you had a real injury, right? This is not something. Now, again, everybody talks about time of getting people back, and that's a whole nother session, right? But I think the most important thing is educating the patient based on your experience and the desire to get them back to the best outcome, and go from there. But I remove the screw. I prefer to remove it between 3 and 4 months, the standard. But I do prefer to remove it. But if they broke it, and some of these more senior athletes, they just won't come back. They'll say, "Doc, I feel fine. I've got hardware all over my body." Right? They won't listen to you.
Yeah, when I look at things, if it screws, am I going to remove it? I'll only remove those if they're problematic and cause symptoms. Otherwise, I tend to leave them in. The one thing, keep in mind that we did a project at the lab looking at flexible fixation compared to a couple of different types, and one of the things that's clear is they're not as good in sagittal plane stability as you load it repetitively, and if it's length unstable, they are not length stable devices. And we presented that at the Foot and Ankle Society this year, but that's a reality. So if it's something that has some sagittal plane instability to it, or it's length unstable, and you load those people early, it will not stay where you put it. Just be aware of that.
Yep.
Well, and you guys have brought this up a few times, so I want to make sure the panel understands, or the audience understands this. The flexible fixation devices, we'll even get into rigid fixation, but at minimum, the flexible fixation devices that are out there will not control fibular length. And so in length unstable fibulae, with syndesmotic disruptions, well, you know what? We're going to get back to that. I'm going to plant that seed in your head, because we have cases that'll describe that. I want to be mindful of our time. So I fixed this person. Thought I had his fibula out to length. I fixed his syndesmosis, and you can see that on that AP, he looks short, and I am freaking out right now. I am perseverating over this. I've looked at my reduction a few times. I've multiple fluoro views. Before you got back on, Michael, are you using intraoperative CT to assess your syndesmosis? I know some people out there are suggesting doing that.
I'm not. And we have intraoperative CT, but in the world I live in, that's generally in the neurosurgery room or our pelvis room. And so for me to try to pull it out to do an ankle fracture, that's just frankly not going to happen. So, like the things that I look at intraoperatively to reduce it, like I said, I dissect over the front of the fibula and literally directly visualize where that goes back in right above the level of the ankle joint. The further up you're, quote, looking in the incisura, the further apart the bones are, and the harder it is to make a good assessment of the reduction. But I look just over the front.
So I did that. I actually went over the top on this guy from my lateral incision to look at the anterior, and I agree with you. It's got to be really distal to really get a good assessment. Looking at that basically that corner of where the talus meets the fibula and the tibia, and it looked okay. Now I will also say that I have gone back and forth in my career about opening and looking at the syndesmosis. I don't feel like I really get a great feel for it when I look at it anteriorly. I mean, I get a rough idea, but I still don't think I'm getting it perfect. And there is literature out there to suggest that even with an open exposure and an anterior visualization, you still can be off because of how the incisura in some people is built. So I'm still not convinced I got it right. Ultimately, I looked at his right side again and really magged in, and you can see that his right fibula is also not dissimilar in terms of its position and how short it is relative to the left. And I also looked at the lateral view, and they seem to be consistent in terms of where they are relative to each other. And he actually ended up doing fine. I didn't do anything more than accepting this reduction, but only because it was relatively similar to the right side or identical to the right side. So I think there's value in getting contralateral films because not everybody's ankle is quite the same. All right, this is a 43-year-old female. I don't want to spend too much time on this case. I just want to get your opinion on something and you're expert. So this is a 43-year-old female, fell on ice. There's no red herrings here. She has a trimalleolar fracture. The medial side extends a little bit posterior. Here's her CT scan. Very small posterior malleolus, right? And so my first question for both of you, and this is not a posterior malleolus talk, is very quickly, are you fixing... You fix the fibula, the ankle is stable after you fix the fibula. Are you still fixing this posterior malleolus with an ORIF? Mac?
Many of those with this size, just sit on the screen. I would probably sneak to place a screw across that. Depending on your exposure, it looks more posterior medial, but this is just what I'm going from the AP. I try to place a screw across that. Sometimes I go A to P. Sometimes I will go P to A. But whatever I can to get there. And again, if I'm really overly chasing it, that's when I would say, you know what, I'm going to immobilize them longer. But I think this is a pretty decent sized piece from what I can see here. But
okay. Michael, are you fixing this relatively small? I agree it's a decent sized piece. I still think it's relatively small. Are you fixing this, Michael?
Yeah, so I mean, looking at this, to me, that looks posterior medial, and you just duck behind the medial side, and you can either bring a screw back to front or front to back. And, you know, we all know that the posterior malleolus contributes to syndesmotic stability. So I would be inclined, if I'm already in the OR, I would be inclined to put some fixation in this, and it'd take, I don't know, just a handful of minutes to make a little incision to make sure it's reduced.
So I guess that's my question. For these really small, and I agree, this is posterior medial, I'll probably fix this. But for these really, really small posterior malleolus fractures that go along with your fibula, I'm sure you guys have seen them, the small avulsions, and maybe this is not a good example of that. If you're not going to fix the posterior malleolus, right? If you're not going to put a plate back there and it's too small for a screw, you guys know what I'm talking about. It's like it's essentially an avulsion, right? Are any of you putting syndesmotic fixation into your ankle in lieu of fixing your posterior malleolus?
The question comes back, do you think they're clinically
Michael?
unstable as a result of it?
Well, that's the dilemma, right? You know that posterior malleolus is attached to the syndesmotic structure back there, right? And so you know that that's been compromised. So, and that's why I'm asking. It's a little bit of a controversial issue, I know, but I am seeing some people not fixing the posterior malleolus with these small avulsions, but still stabilizing the syndesmosis in lieu of posterior malleolar fixation. And so I guess my question is, what are your thoughts on that?
So the worry is, if that posterior mal is small and it represents an avulsion injury, that's the syndesmotic injury that when you look at your mortise view in the OR, it's more likely, it may not be like medial to lateral widening, but the fibula may translate anterior in the sagittal plane. That's a hard thing to see. And so, you know, if you are going to fix a syndesmosis as a result of this injury and leave this piece alone, the worry I have is you need to make sure in the sagittal plane that your fibula is in the correct location of the incisura, and that's the hardest reduction to do. I think reducing that piece for me is easier than always knowing I'm 100% accurately in the correct plane, in the sagittal plane when I reduce that. But that's what late reconstructions, when I see these patients who have this type of injury, and you get a CT scan of both ankles, the fibula is anterior.
Mm-hmm.
Yeah. Max, similar thoughts there?
Yeah, absolutely. Nothing to add there. So that's exactly my thinking.
Perfect. Yeah, I mean, I think that's my position as well. I mean, I think, you know, when you see these small posterior malleolar avulsions, there's injury back there. We know there's injury back there. We know the syndesmosis, that the entity has been compromised, but they're maybe too small. And I know there's people out there with any posterior malleolar injury, they're going posterior and they're putting a plate back there. And I always wonder, are they really fixing the bone, or are they just grabbing the soft tissue? And it's really a soft tissue repair that they're doing, right?
Mm-hmm.
And so I just bring that up as a point of discussion, but we have plenty of other cases to get through. I ended up going in the back and fixing everything and rigidly doing it. So the syndesmosis was not an issue because I fixed the bony part of the injury.
Mm-hmm.
All right. Similar scenario, fall from ladder. Michael, this is your case, I believe. Small posterior malleolar avulsion, a proximal fibula fracture, right? Here's your posterior malleolar injury. You've got that sort of medial extension of it, which makes it a little bit more, I think, even more unstable. On this view, the syndesmosis looks reduced, I would say, but we know she's got the proximal fibula fracture. Mac, talk me through how you're approaching this injury in terms of sequence and fixation strategy.
Yeah, I'm definitely viewing this as an unstable injury, and from the Mason component and the comminution of the posterior malleolar component. The advanced imaging, same I would utilize, and then I would go in with a plan of having plate fixation. These pieces are a little too small for screws. I mean, you could grab them, but if I want to have rigid fixation, I would go in with a plan to do a posterior medial fixation. I would plate them posteriorly. I would try to go with small, low profile plates, but they get the job done. And you made the point earlier. I mean, if you're going to go posterior, it is a soft tissue procedure as well, and just making sure you release as much of the deep posterior compartment as you can to minimize, sequelae of a deep posterior compartment syndrome postoperatively, and also minimize how much the FHL gets scarred down. So I try to go low profile plating.
Okay. All right. So Michael, beautiful reconstruction, a couple of small mini frag plates, buttressing that posterior fracture fragment. And so talk me through, Michael, why you chose to use flexible fixation here after fixing the posterior malleolus.
So yeah, this is kind of a weird case because, like you said, when you look at the CT scan, you can see there's the posterior malleolar injury that's a multi-fragment injury and has a proximal fibula, but the syndesmotic relationship looks actually pretty good on the CT scan, right? It's in the groove, the spaces are equal. So in this case, same thought process that Mac just shared. We use small plates, fix the fragments anatomically, and then when I was done, I stressed the syndesmosis. When you fix the posterior mal, this is a little bit different injury because clearly this injury extended up the interosseous membrane and out like a Maisonneuve. So that's essentially what happened here is I fixed the bony component, stressed it, and it was still unstable. And our fibula length was good, so it needed some syndesmotic fixation in addition to the posterior malleolar fixation.
And do you think there's a difference between an all soft flexible fixation device compared to a device like this, which is a combination of a screw with soft fixation?
I do, and there's a couple different reasons why. So if you look at the more commonly used flexible devices, your fixation is far away from the actual injury. It's on the medial cortex and the lateral cortex of the fibula. In the size of your hole, right? Your drill is based on the point of anchor as opposed to the device that crosses the syndesmosis. So I think they're a little bit more prone to some length and sagittal plane instability for that reason. And this gives you rigid fixation in the bone, and the area that's flexible is actually just at the syndesmosis. And so because you don't have that same amount of potential excursion, and through cycle, this doesn't creep, it provides some length stability as well.
All right, let's go on to our, before I forget, when are you letting this patient weight bear? Mac, you first, since it's Michael's case. I want to see what you'd say before Michael says it. So when are you letting this guy weight bear?
So I would probably start partial weight bearing protocol around 6 weeks. Now I hold people back a lot longer. I think they do too much. So I put him in a splint for 2 weeks. Then I put him in a cam boot, start ankle range of motion. If the soft tissues have calmed and I really trust them, I would consider a partial weight bearing protocol starting at 4 weeks. And I don't take them out of the boot until around 8 weeks. If soft tissue issues, other dynamics going on and factors, I will start that at 6 weeks, and they won't come out of the boot until 8 to 10 with a lace-up brace. So everyone's it's unique across patients. So patient-specific approach.
Okay. Michael, when did you let this patient weight bear?
6 weeks. So he was a splint for 2 weeks, put into a boot once the sutures came out at 2 weeks, and then advanced weight at 6 weeks.
And no plan to remove that flexible fixation device, correct?
No.
Okay. This is a gentleman who fell 10 feet this evening. He reports he was dangling from the second-story balcony in an attempt to leave his house undetected by his sister so he could go to the strip club with his friends. Yep. Welcome to our foot and ankle population, right?
Mm-hmm.
At least he was honest about what he was doing and why he was going there. So this is his injury. Pain in his right ankle. You can see the widening of the medial side. You can see somewhat appears to be gapping of the syndesmosis. Of course, really important to get a reduction, but also proximal films. And he's got a proximal fibula fracture. I'm sorry, this guy does not have a proximal fibula fracture. That's a different case. So this is an isolated syndesmotic disruption with no proximal fibula.
Mm-hmm.
Okay. How do you want to treat this? Mac. Ooh, oh, I don't want to do that. Mac, you first.
Go back to the original image if you don't mind, AP.
Yeah.
So again, injury, patient specific, right? I mean, and in this scenario, based on what you mentioned and some of the decision making, I would want rigid fixation with this. I would often go with a 2 or 4 hole plate with no fracture. I would also evaluate his deltoid intraop, as I mentioned previously, if I felt I could not get a good reduction, I would actually repair that with anchors, and then I would do a buttress plating and solid screw fixation. Or I would consider hybrid, but
Okay.
I want this guy to be a little more rigid with the history and the decision making you laid out at the beginning, and that really does drive that.
Yeah, no, I wouldn't blame you for this. Michael, you doing the same thing, rigid fixation with this, or are you going flexible?
I would do kind of that construct that I used in the last case, where it's rigid in the bone and flexible across the syndesmosis.
And are you just using one of those devices, or are you going to use multiple devices?
I would use one, but this needs to be opened up,
Okay.
And fibula put back in the incisura, and then that taken care of, and then see if there's anything else going on the medial side that needs to be repaired. But yeah, one device. My whole thing is I can never really know if you're going to use 2 flexible devices. I always wonder, like, is the second one doing anything? How do I equivalently tension them? Is I just have the other one in, like, to make me feel better? I don't know what the benefit of 2 flexible fixation devices. Like, if one's not going to do it, I'd be more inclined to add a screw as opposed to a second flexible device.
Okay, that's a good point. How are you guys getting? So when you say you're doing your reduction, you're opening it, and then are you clamping it, Michael? Are you manipulating it manually by hand? How are you putting the fibula back in the incisura if you're opening it?
So a case like this, I'd make a lateral incision right down the side of the fibula. It doesn't need to be a very big incision. dissect over, there's usually a fair amount of hematoma and debris between the fibula and the tibia. Pull that out. You can see the top of the talus in that location. And I take the fibula and directly with my hand reduce it back in the incisura. And then while I hold it reduced, I take a pointed reduction clamp from the tip of the fibula to the tip of the medial malleolus, which really recreates your malleolar axis, right? Goes right through the center of the syndesmosis. I put that on, and then I put a wire up a little bit higher up so that when I introduce whatever device I'm going to introduce, if I don't put it in the correct plane, I don't introduce an alteration in rotation as I introduce my fixation device, whether it's flexible or rigid. Then after my device is in, I take the clamp and the wire out.
Great. Mac, how about you? How are you getting your reduction of the syndesmosis? If you're not opening it,
yeah, I will. If I'm not doing full open, I use a combination of a clamp, and I actually use a wire that I place from the distal tip of the fibula, really angled almost in the direction of this syndesmosis, essentially going from the distal tip of the fibula into the tibia diagonally to hold out my length and reduction. And then in some scenarios, the point that Michael made of putting a proximal pin, I've done that in the past. But if I feel good about things, I then hold everything there in that position and then come in with my plate fixation.
All right. So this gentleman took him to the OR. One of the things that has been popularized, at least in the trauma world, is when you're doing these acute syndesmotic injuries, as long as your fibula is out to length, that really manual compression, if you're not opening the syndesmotic joint, manually squeezing the fibula and tibia together should be enough force to be able to reduce the fibula into the incisura. And then if you're using a large periarticular clamp or a large Weber clamp to compress the fibula into the tibia, and you're sitting there and you're squeezing it and it's not going back, or it's requiring that much force to reduce, that you're likely malreducing it, right? So I think one of the things I want to make sure the audience leaves with is it shouldn't be a struggle to put the fibula back in the tibia. If it is, there's something else going on. Would you guys agree with that statement?
Yeah, I completely agree with that, but the reason I put the clamp on after I reduce it, because then I get two hands back to operate. Similar to the beginning, I don't know what to do with my hands. I would say I don't know how to do this without my hands. So I reduce it by hand and then use the other stuff to hold it so I can use my hands to put my fixation in.
So I used a 1/3 tubular plate, kind of like what you said, Mac. I put 2 screws in. I put this guy, I don't typically cast many people, but I casted this one. And that was him. I think 6 weeks go by. He shows up in clinic, had been walking on his splint, and he's already got a broken screw. And you can see that he's already got talar tilt, and he's already failed my reconstruction less than 6 weeks. I think it was less than 6 weeks after surgery. So now what? Mac, what are you going to do for this guy? Again, he's not the most compliant person.
Yeah. And this, after this, we have failure fixation, obviously have a compliance issue, but I wouldn't leave him in this position. I mean, we know this is likely going to end poorly and give him more long-term issues. I would go back in with even beefier fixation. I mean, this was solid and well done. So I would possibly go in. I've gone up to 4. I've done as many as 4 transfibular screws, particularly for someone who may be diabetic. And then also, I will give them prolonged casting. I mean, if necessary, and just let them know that. Yeah, bigger. Okay.
So I did that. I went beefier, and I put him in an X fix because I didn't trust him. I really put him in the penalty box.
Yeah.
Michael, how do you feel? Michael, how do you feel about this? X fix, 3 big screws. I think I got him back to where he needs to be. I did get a post-op CT, and I was it wasn't perfect, but it was really, really close. So what do you think now?
Yeah, I think that's fine. And the other thing you could do is go just like you did and add a flexible device, because if these other devices break, you still have some stability. And if I'm going to put the patient in the penalty box, I'd really put him in the penalty box, and I would make one of those X-fix bars longer than the other. So if he does try to step down,
Yep.
he's not stepping on his foot. He's stepping on one side of a pin that's in his tibia, so to speak, just so he
Right.
can't put his foot on the floor.
100%. I love it. Yeah, no, there are strategies to help patients who can't help themselves.
Mhm.
So I wait 8 weeks and take him back to the operating room. I take off his X-fix. I stress his syndesmosis. I stress everything, and this is what I'm left with. It looks pretty good. So now he's 8 weeks, almost 9 weeks after his second surgery. X-fix is off. He has not been able to walk on it because I do the same thing, Michael. I basically make my X-fix in a way that if he tried to put his foot down, it's not, the foot actually can't hit the ground. And he was pretty miserable, but he was as compliant as he would be. I mean, I'm pretty sure he walked on whatever construct I had, but he didn't actually put weight through his foot. Are you letting this guy weight bear at this point in a boot? I put him in a boot just to protect him a little bit more. Michael, yes, no?
Yeah, I would let him start putting weight on. I'd put him in a boot because it's an extra rotation type injury, and it controls rotation.
Great.
If he wears it.
Great.
Yeah, exactly.
Great.
Yeah.
So this is
Same.
him. This is him at 6 weeks. This is him at 12 weeks, before 12 weeks. So now what?
This is a different issue. So if you look at your central image, his plafond, the lateral aspect of his plafond now upslopes, right?
Mm-hmm.
Yeah.
See that? And if you look at his lateral view to the right, you can see there's something bony posteriorly. So he, at this point, is not a purely ligamentous injury. He's got deformation of his plafond. And you can go in and put syndesmotic fixation in it, but he does not have a congruent ankle joint. And this is, in my opinion, destined to fail at this point.
So,
Agreed.
So what to do for him? Because he's not the best patient, as you can imagine. So what do you want to do for him?
Does it bother him?
Yeah.
Still has pain.
Yeah. It feels like he's walking on the side of his foot. Yeah. So to keep going, I ended up doing this. Took him to the OR, fibular osteotomy, a distractor to get length on the fibula, drive that talus back. As you noted, Michael, the talus is starting to go in a direction you don't want it to. So distractor almost over lengthened the fibula, if you will. And then once that was done, some lag screws for my osteotomy, a large plate, big plate, and then I put in flexible fixation here, 2 points of fixation. Again, I'm not sure if there's value to this or not. And then that's his lateral, that's his AP, and then that's him at 8 weeks, and he's stable and he's walking on it.
Just out of curiosity, did you CT it before this reconstruction?
I did.
And his plafond
Small
looked okay?
Posterior malleolus. Plafond looked okay. There's a posterior malleolar component.
Yeah.
That I think I must have missed on his original films or his original injury. So
yeah, or when his fixation failed and his syndesmotic area widened, like you can have a syndesmotic injury and repair and fail your repair in a different portion of your syndesmosis.
Right.
Yeah.
Because looking, I didn't see anything that's posted on any of the other images.
Yeah.
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 Nice. All right. 34-year-old male, rollover snowmobile injury. You can see his medial widening there. He could not tolerate a stress view. This patient showed up in my office. And so he showed up with this x-ray, and, we sent him back to radiology for a stress view, and he could not do a stress view, which was a little surprising to me. It's been probably about a week or so. And so I was a little surprised by that. But he also has this image here. Okay, so he's got a Mason-New. And so how do you, and I apologize. I actually think this injury was about 2 weeks or 2.5 weeks old by the time he got to me. How do you now reduce this syndesmosis. Even though it's a fibular fracture, really it's a syndesmotic issue at this point. So how do you reduce this syndesmosis? How do you get him back to where he needs to be? Are you opening this distally as well?
Yeah.
Michael first, then Mac.
I think that you have to, and if you go to the lateral view of his proximal injury in his fibula, he looks short.
Yep.
And so, while you don't need to open that and put a plate on it, you do need to get some length back. And so what I'll do is I'll open things distally, and there's a articular facet on about 83% of the population on the Chaput side, and you can see it on the fibula if you really look for it. And then what I end up doing to put length is I put a couple K-wires or a 4 millimeter Steinman pin in the fibula, and then just in front of it, I put one into the tibia, and I put a lamina spreader in between, and then you can get your length that way, because it's you're not going to grab this with a pointed reduction clamp and pull it out to length. You're just not. It doesn't work like that 2 weeks out.
Such a critical point. You can't just fix this. I think what you're telling us, Michael, is you can't fix this fibula in situ, right? You can't just put a screw across this or a flexible fixation and malreduce the fibula to the tibia because the fibula is short. But you also need to get length, and you're not going to get length by just pulling on a 2.5-week-old fracture like this. Fair enough?
Right. Yeah. Yeah.
You got to drive that. Yep.
Putting the fibula into the incisura is not the difficulty of this case. It's restoring length to allow the ankle alignment to normalize. That's the hard part of this one. Like you said, 2 weeks out, that's a challenge.
Mac, are you doing anything different to get length on these patients?
No, same approach. But if I find that I cannot get length, I will reluctantly but appropriately go proximal, and we'll put a small plate. Obviously being respectful of the soft tissues.
Yeah. And so that was his other side. You can see his fibula is out to length there. And so as we keep going, just to be mindful of the time, I ended up going proximal. I could not drive his fibula distal. It was, and maybe I should have done what you suggested, Michael, which is put basically, it's not really using a distractor, but the concept is the same, using 2 points of fixation and driving that fibula distal, but end up opening and reducing the fibula. One of the things I'm always amazed by, and maybe you guys would agree with this, is once you get fibular length, it is always amazing to me how the fibula, it stay. I mean, I have stressed these after I fix the fibula like this, and the syndesmosis is stable. Right. I don't know how to explain it. I mean, I have put and I'm not sure if the syndesmosis is truly disrupted or if everything is shortened. And by the time when you pull everything out to length, it tensions the soft tissue again. But either way, I still put some flexible fixation across his ankle because I felt that, I wanted something down there. But, crazy, you think? Michael, you sort of said you don't usually go proximal, but you got to get length, right?
No, I don't think this is crazy. I mean, at the end, you need to do what's necessary to restore the appropriate alignment and relationships of the ankle. And if you can't get that done by other means, where the deformity is. It's at that fracture. And, if that's what it requires to get it restored, then I have no problem doing that. Yeah,
same. Any means necessary.
Right. One last case, and I think it highlights so many things that we talked about today. And I know we only have a few minutes left, so I'm going to go through the case. If you guys want to chime in, just go ahead and say something, but because I do want to leave a couple minutes for questions and for Selene. 23-year-old male, skiing injury. I don't have a lot of his films because he went to, he sort of got to me a couple surgeries in, had right ankle pain. This started all in 2021. This was his CT at the time of his original injury. You can see a relatively large posterior malleolus fragment. I suspect most of us would have gone after that, and a widening of the medial side. What looks like syndesmotic disruption, is that truly a syndesmotic injury or a large posterior malleolus? Either way, he had fixation, and he at 6 months, this is what his x-rays look like, multiple broken screws. He had medially based pain. He had difficulty weight bearing, and he had intact soft tissue. You guys good with this so far? We've already seen cases like this. This goes back to your point, Mac, of over fixing the syndesmosis. but they didn't address, to your point, Michael, earlier, they didn't address his bony injury really. And this is a very different animal that we talked about. So, you know, I look at him, I'm like, well, your fibula is out to length. It looks like your talocrural angle looks good. You know, your medial clear space is wide. He's got, you know, tib-fib overlap is poor. And so this is again still at an outside hospital. He ends up having some of the hardware removed. He has a deltoid repair with some kind of a soft, like a suture repair through drill tunnels. And he has a flexible fixation device put in. Satisfied with this? Michael, are you satisfied with this?
No, and you know, if you're going to repair the deltoid and you're going to switch your fixation up, you have to get that fragment that's between the tibia and fibula, because there's threads in both bones. So you can't change your syndesmotic reduction without removing that piece. And so all the other stuff is great. And when you look at the slide before, you can see he's got some bony debris in his medial gutter. But like, in order to change the position of the fibula, that fragment, it has to be removed. Otherwise, you're not moving it.
Yeah. Well, it gets even better. So this guy then shows up 3 months later in my office with a draining wound medially, a sinus tract down to his medial ankle, pain and instability. So he's got a failed ankle repair. It's been going on now for almost over a year and a half. He's infected, clearly infected, with retained hardware. And by the way, nobody bothered getting proximal tibia films. So he has a fibular malunion proximally with infected ankle hardware distally. So just to finish this up, because I see Selene on the screen. Go ahead, Michael, real quick. You're going to say something.
So this one, all hardware comes out. He gets antibiotics. He's 23 and likely healthy. Stage everything. Go in. You can do a lengthening osteotomy or go up top and recreate his initial fracture.
That's exactly what we did. Took everything out, gave him antibiotics, gave him a holiday from his antibiotics, cleaned everything out. And he's 8 weeks now, and we'll see what happens to him. But we did exactly that, which is lengthened his fibula, got rigid fixation, and he's weight bearing. And well, fingers crossed. So I want to thank you guys for your time. Really, hopefully people in the audience got something out of this. A lot of great discussion and debate. And so Selene, audience is yours.
Yeah, great job, guys. Thanks, Samir, Mac, and Michael. Thanks, you guys. Great job.